I thank all the speakers and the panelists and chairpersons for the wonderful session. Now we'll move on to the next session, which is on Treat with Care, Critical Care for Special Groups. I would like to invite upon the Chief Moderator, Dr. Muralidhar Kanji, Academic Director, Senior Consultant and Professor Anesthesia and Intensive Care, Narayana Institute of Cardiac Sciences, Narayana LCT, and Dr. Asina Jahan Lopa, Dr. Shashi Bhushan BL from Suguna Hospital, Bengaluru, Dr. T. Mohan S. Maharaj, Director of Critical Care Services, Medicover Hospitals, Vizag, Dr. Anusha Cherian, Professor Anesthesiology and Critical Care, JIPMER, Pondicherry. Welcome all.
I take great delight in welcoming you to this session on critical care for special groups. Thank you so much for joining us. And I would like to ask one of my co-chair to introduce the speaker and get the session started.
So now I would like to invite Dr. Prakash Shastri, who is the, So Sir is the Senior Consultant and Chairman, Critical Care and Emergency Medicine, Sir Gangaram Hospital, and he will talk on Treat with Care, what is that? Care, Critical Care for Special Groups. So over to you, sir.
That happens when you're very familiar. Lopa is a personal friend, and she was finding it difficult to introduce me. But that shows the love and affection that she has for me. Thank you very much, Lopa. And the topic that has been given to me is oncological emergencies and intensivist perspective. Now, when you talk about oncology patients, now once upon a time, 10 years back, my hospital was not an oncology hospital, and that's why we would get mostly post-surgical cases and solid organ transplant at the most. But in the last 10 years, with the hematology taking a big leap and bone marrow transplants becoming very routine in the management of so many conditions, we are seeing a lot of these patients, and that is what I would focus on. Hopefully with the with the time that is available to me, I might be able to cover only the stem cell transplantations. So just for the beginners who are here, syngeneic transplant is one which is from an identical twin. Allogenic is from a donor. The donor could be a related donor. It could be an unrelated donor, but it could be a matched donor. So we call them MUD. Autologous would be the stem cells which have been derived from the patient's own source, which could be a bone marrow, which could be peripheral blood, or which could be a cord blood. So these are the various complications that happen after stem cell transplant. And the reason why most of the patients tend to get transferred to my ICU is apparently transplantation related lung injury. I wouldn't agree with that. What I would agree is that lung is just a manifestation of the systemic infections that these patients have, and that is why they end up into the ICU. Now listen to this slide very carefully. Now patient is come to you and he may not be showing signs of sepsis because of various reasons, and this various reasons, one of the most important thing is that the patient is immunosuppressed. Now the response of the patient to the infection that occurs, and these patients are sitting duck for infections, I must say, and is dependent upon the net state of immunosuppression. The net state of immunosuppression is contributed to by organ dysfunction on one hand, the presence of the flora and fauna, that is which organisms are common in your hospital setup, and then among the infectious agents, the ones that I'm most scared about is what is called as immunomodulatory virus, and one immunomodulatory virus stands out is CMV virus. So when I talk about a net state of immunosuppression, let us say I give a figure of 100 to the net state of immunosuppression. The addition of CMV viremia in this patient, the net state of immunosuppression will go up to 150. And that much more difficult it becomes for me to treat these patients. And there are several other factors which contribute to the net state of immunosuppressions. I will not go into the entire details of it, but what I need to tell you is that what happens after the stem cell transplant has been given, the patient's bone marrow is irradiated completely and then they recover, then it recovers. How long does it take for the recovery to take place? It might take weeks to months. And this is the period when the patients are particularly vulnerable to infections. So I'll take you to a case, 38-year-old gentleman, myelodysplastic syndrome, refractory anemia, underwent a mud transplant almost more than a year ago, almost 2 years ago. He comes back with a relapse with medullary and extramedullary disease. He's on intensive chemotherapy. The hematologist has tried his level best to control the situation, but the neutropenia is persisting. The fever is persisting. We might be able to get time for neutropenic fever later on. Now he develops skin lesions. I don't know whether you can make out, these are skin lesions. They are very suspicious lesions, especially in a person who has got such a huge net state of immunosuppression. Any takers? Anybody wants to have a wild guess what it is? Anybody? A wild guess? See, it's rare for intensivists to come across this kind of situation. TLC count 200, absolute neutrophil count 0, nil bate sannata. Creatinine is normal, urea is okay, LFT, slight hyperbilirubinemia but no transaminitis. Galactomannan is 2.162. The blood culture is awaited. Can I go back again? Now that I've told you the investigations, any wild guesses at the diagnosis? Still nobody? Okay, fair enough. Chest X-ray, CT scan, left side lower lobe consolidation present, other than probably unremarkable. We call all the people involved, the ID people and their physicians and everybody. This was the differential diagnosis we got. All related to fungus except one, because they know that Klebsiella is very common in my ICU. They said it was gram-negative bacteremia, probably Klebsiella, maybe Pseudomonas with ecthyma and septic embolization. That's why you could see those lesions in the skin. Skin biopsy was done. Leukemia cutis, that is a kind of diagnosis was got, with septate invasive fungal infection. Now, septate fungal invasive infection in my book is Aspergillus. Beyond that, maybe I can think of Scedosporium, but beyond that my knowledge finishes. It stops there. I won't go more about that. But the culture reports said Fusarium species. Now, Fusarium species more seen in agriculture workers because the Fusarium species is more common in crops like wheat and rice, and usually the farmers who are working in these fields tend to get it. And it's an uncommon disease. The problem is that very resistant to all classes of antifungals. Voriconazole is the drug of choice, but whether it works or not is anybody's guess. The blood culture also showed Fusarium. So the reason why I brought up this case was that when you're dealing with a patient who's immunosuppressed to such an extent and is coming to you with features with sepsis, the etiology can be anything. Polymicrobial infections are more common, and that is why you have to make very aggressive approach to biopsy to diagnose these patients, and that would mean that you should not stop short of doing a CT guided biopsy in these patients. Or you can do a bronchoscopy, but the trouble is that these patients would well be thrombocytopenic, and your pulmonologist or whomsoever is doing a bronchoscopy may not be very keen to do it. So you have to basically depend upon presumptive treatment. So the critical care considerations come in because of toxicity of conditioning regimen, a lot of drugs that are given pre-engraftment. There's immunosuppression because the immunosuppression that is given after graftment, and then invariably when we have a bone marrow transplant, we have a condition called graft versus host disease, and these can occur from 10 to 40% of cases, and these patients, among them, a good number, almost 60%, would go on mechanical ventilation, and they have a very high mortality. So that becomes a emergency in my book. So when we talk about neutropenic fever definitions, you should know what is fever, anything more than 101 or anything more than 38.5 degrees centigrade. Neutropenia less than 500. So this should be very clear in your mind. And when you are dealing with a neutropenic fever, be a decider. Don't procrastinate. You will be absolved of all the crimes of antimicrobial stewardship. Give broad spectrum as possible, and give it as soon as possible. Shoot first, ask questions later. Empirical treatment, GNB, GCB, everything. Don't wait for the counts to become normal. Just keep on giving the antibiotics. And when you're okay, so the antibiotics will be dependent upon the likely degree of immunocompromise. I told you have to judge or estimate the net state of immunosuppressions. What the prophylaxis the patient has been getting in my hospital. Most of my post-transplant patients, post-bone marrow transplant patients, are antifungal prophylaxis in the form of posaconazole. There are anti-PCP prophylaxis in the form of Septran. And then obviously the environmental exposure, whether the patient has a travel history or anything of that kind, that will decide. CLL on chemotherapy has massive splenomegaly, intra-abdominal and retroperitoneal lymph nodes, hemoglobin 11.4, TLC 96,000. No wonder he is a leukemic patient. Platelets 108, thrombocytopenia has not set in as yet. BUN creatinine, LDH is 597. Now this patient undergoes chemotherapy for his CLL. On day 4 of chemotherapy, he presents with flank pain, generalized weakness and nausea. BUN and creatinine, which were low or normal before, has shot up to 55.2.4. Uric acid is 18. LDH has gone up 3 times almost to 1800 international units per liter. Sodium 132, potassium 5.9. What is the diagnosis? Yes, exactly. In addition to IV fluids, which of the following interventions should be initiated? Rasburicase, CBJ, hemodialysis, continuous renal replacement therapy, urine acidification. The idea is to get the kidney going, and if not, the kidney is not going, then probably you have to go for an early dialysis in this patient. Rasburicase has been tried. It takes away the uric acid. So Rasburicase would be the right answer. So important thing in tumor lysis syndrome is that you should anticipate it rather than treat it once it has happened. So there are some aspects of prevention that include adequate hydration, use of uric acid lowering therapies, use of phosphate binders, minimization of potassium intake, and patients who are expected to be at high risk for tumor lysis should be monitored in the ICU. A quick case, superior vena cava syndrome. I have got a patient right now in my ICU. He has come with a thymic tumor. We have diagnosed him as squamous cell carcinoma of the thymus. Now this is the first case that I think I have seen in my lifetime, but he has got squamous cell carcinoma, but it is unresectable from the surgeon's point of view. So we are giving him chemotherapy for the time being. 3 cycles have gone by. Next Monday, tomorrow, or day after would be the 4th cycle. The tumor is not showing any signs of regressing, and this fellow is not able to lie down properly. We stented the trachea, thinking that the tracheal stenting would improve the airway and reduce the compression. Nothing. We did a tracheostomy, and despite all that, we have not been able to get him off the ventilator. So airway obstruction is the reason why these patients come, and we have to secure the airway, but until the cause is created, until the compression on the trachea is removed, this problem will not go away. And that is why perhaps after the next chemotherapy, we might give a short course of radiotherapy in this patient and then maybe do a debulking surgery. We know that we will never be able to debulk it completely, but we will obviously try to reduce the size of the mass. But commonly, the lung tumors or pulmonary neoplasms are the cause of this kind of superior vena cava obstruction, and 75% are caused by lung cancer, 25% are caused by lymphoma. So that is why I had to mention that I have a case in my ICU right now, which is actually thymoma, which is again an anterior mediastinal mass. So anterior mediastinal mass is a treatment versus diagnosis. I've already talked about the various modalities of treatment: tracheal stenting, debulking, chemotherapy, and then early biopsy. We have done an early biopsy and we have got the report as squamous cell carcinoma, and that's what that can lead us to the possible treatment in this case. Sometimes we get patients acutely in our ICUs which have got spinal cord compressions. Remember, spinal cord compression can occur in those cancers which spread by hematogenous route. So we have the breast and the lung and the prostate, renal cell carcinoma, and then obviously the lymphomas and myeloma, which may cause spinal cord compression. When it is spinal cord compression, the thoracic spine is the one which is more commonly involved, lumbar spine is next, and cervical spine is very rare. So the chances of these patients coming to the ICU is not very high, but still with cervical spinal cord compression, airway becomes a scapegoat, and that's why you need to come into the pictures. Hypercalcemia can be due to various cancers which might end up into the ICU. I don't care about treating the hypercalcemia. People talk about calcitonin, people talk about the phosphodiesterase inhibitors and all that stuff. But I hydrate these patients well and I dialyze them as soon as possible. So thank you very much for your patient listening.
Thank you, sir. We'll take questions in the end of the session. I call upon the next speaker, Dr. Nandita Divakar. She's a consultant in critical care and anesthesia, Midway NHS Trust, United Kingdom, and Secretary of British Association of Indian Anaesthetists. She'll be talking on treat with care, critical care for special groups. Over to you, madam. And I to detail antibiotic stewardship in neutropenic sepsis.
Sorry. How do I start from the beginning?
First one.
Yeah. Good afternoon, ladies and gentlemen. Thank you to the organizing committee, to the chair people, for inviting me to speak at this wonderful conference. And my topic for today is an eye to detail antibiotic stewardship in neutropenic sepsis. Let me tell you about an incident. A few years ago, I was in a city in northern India for a holiday, and while going back, I started getting symptoms of UTI. So when I went back to England, the GP started me on Augmentin, and we sent the urine for culture. And guess what? The microbiologist rang me up and said, Nandita, you have got ESBL. Wow, I hadn't had antibiotics for nearly 2 years. I hadn't had. And it was resistant to everything, so poor Dr. Divakar had to have IV meropenem for 5 days. I was really unwell with it. That's resistance, isn't it? Antimicrobial resistance, or AMR, occurs when bacteria, viruses, fungi, and parasites no longer respond to antimicrobial medicines. The emergence of antimicrobial resistance poses a global threat. High-risk patients, such as those with neutropenia, particularly vulnerable to opportunistic infections, sepsis, and multi-resistant therapies. Now, please, show of hands, who has an antibiotic policy in their hospital? Who has an antibiotic policy, please, show of hands? And who has AMS, antimicrobial stewardship teams? Fantastic. Why do the rest of you not have it? Please have a think. So, resistance to antibiotics has led to at least 1 million deaths since 1990 per year. And it's increasing, and it's supposed to increase in the next decades by 70%. 39 million deaths between 2025 and 2050. 3 deaths per minute. Is that scary or not? And possibly we are responsible for it. The finger points towards you all, and me, of course. Deaths from AMR are going to increase in the 5 global groups. Look at that. Western Sub-Saharan Africa, Latin America, North America, Southeast Asia and South Asia. Researchers have predicted that South Asia, India, Pakistan and Bangladesh is going to contribute to 11.8 million deaths due to AMR. That's here. That's in Bangladesh, Dr. Jha, everywhere. You guys are going to be very, very busy. What's the situation in UK? Yes, the deaths have increased. Antibiotic-resistant infections have increased. Thank you, Dr. Shastri, for making my slides easier. You have defined what is febrile neutropenia. And when it is associated with sepsis, the mortality goes even higher. And therefore, appropriate timing of the likely antibiotic is one of the cornerstones of therapy to prevent deaths and life-threatening infections. Now, you remember that tomorrow there is a debate saying which is the most optimum time for the first dose of antibiotic. What are the risk factors? We said immunosuppression, malignancies, post-chemotherapy, post-transplantation, some of them these are. And what are the organisms mainly involved? Gram-negative, mainly E. coli, Pseudomonas. We saw a case of Klebsiella, Enterobacter, Acinetobacter. Gram-positive, coagulase-negative staph, mainly in the lines strep, staph, and the resistant ones, MRSA, VRE, CPE. And then look at the fungal ones, Aspergillus, Candida, and also virals, yeah? CMV, EBV, and then of course PCP. Now there is a paper by Dr. Zirpe and all, we showed these are the main ones. And look at that development of New Delhi beta-lactamase, carbamidase amongst the gram-negative organisms is a culprit there. Sources of infection, most common is colon. Post-chemo gut translocation is the problem. Soft tissue, maybe thrombophlebitis, abscesses, and bloodstream infections, chest, urinary one. Okay, so what is UK doing about this antibiotic resistance? UK government has developed a 5-year program, National Action Plan confronting antimicrobial resistance between 2024 and 2029. We are part of it. It aims to optimize the use of antimicrobials, reduce the need for an unintentional exposure to antibiotics, and support the development of new antimicrobial agents. So what is antimicrobial stewardship? This was described by McGowan and Dale Gerding that applied the term antimicrobial stewardship to optimal selection, dosing, duration of antimicrobial treatment, resulting in the best clinical outcome and minimal side effects and minimal impact on subsequent resistance. We want to solve. Why do you think perhaps we are getting more resistance? Because we are prescribing various antibiotics. Some people don't have policy. Some people, there's a hierarchy. Nobody can challenge the seniors saying, why have you stopped? Why are you prescribing this? And people are starting the last line antibiotic first because they want to get a better cure. I'm going to tell you something. This happened to my brother-in-law. He was admitted with urosepsis. He's a fit person. He's got mild hypertension. And he was admitted because of some prostatic problem. And he said, oh, fine. And then the reports came. He was started on meropenem, while his urine had E. coli sensitive to Augmentin. When I asked the doctor, I said, why directly meropenem? He said, cure ho gaya na, there's no problem now. So this, and then I was, they told me don't ask the question to them because they have to face him later on. So because this was in India, I rang up from there. This is what's going to happen, and this is possibly going to lead to more resistance. Okay? So it's a coherent set of action which promotes the responsible use of antimicrobials. So it applies to national and global level as well as to human and animal health and environment. So for that we need AMS teams with strong leadership, with the backup from the management, with good financial resources. We need consultant microbiologists on it, IT specialists, governance teams, again the clinicians. Pharmacists are very important because the pharmacists, antibiotic pharmacists will see what antibiotic is being used, is the dose correct, what happens. They come and tell us, oh, you have prescribed too much, the dose is not correct, the dose has to be reduced in, say, whatever, renal failure and all, somebody has forgotten to do so. Can you adjust it, please? And that's very important. That reminder is very important for us. They also tell us if we run infusions of vancomycin, we run infusions of gentamicin, they tell us when to take the trough levels. Yes, we have got a policy and all, but they keep reminding us. Administration, nursing head for dissemination of all information, IT. Okay, very important. And the CDC has also outlined the 7 core elements. We said about the financial information. We need to be accountable. We are accountable to our CEO. The CEO is accountable to the state and to the national level as well. Pharmacy expertise, all actions which are taken, tracking of various antibiotics, the usage, the resistance patterns, reporting to the higher level, and education, education, education. If you don't educate the population, if you don't educate your nurses, doctors, your juniors, they are going to look after you. Remember, you don't want to be one of the 3 dying every minute. So there you go. And therefore, what are the barriers? Lack of motivation, lack of education, lack of resources. Now, we also follow this, but we have 3 consultant microbiologists with no juniors. Such a big hospital, 500-bedded hospital, how are they going to manage all this antimicrobial stewardship? And fear of the attending clinicians of suboptimal coverage in high-risk neutropenic patients. Okay, so Medway Hospital is doing it, as I said, but we don't have results as yet because we've just started doing it. Is there any evidence that it works? Yes, there is. Various papers have suggested reduction in broad-spectrum antibiotic consumption, reduced length of stay, reduced costs, and implementation for neutropenic patients high risk, robot carbapenem and glycopeptide usage. It increased the susceptibility to certain antibiotics where they were resistant, but less MDR is not known. One of the Brazilian papers studied that and they didn't show less multi-drug resistance. Now we have the NICE in England has suggested SSTF, Start Smart, Then Focus Antimicrobial Stewardship Toolkit for Inpatient Care only. So what do? That is Start Smart. First, you take evidence of infection, as we said, history of previous admissions, history of previous antibiotics, whether they were resistant to it, any antifungals, any recent chemotherapy, any cisplatin used recently, then you can't use the gentamicin or amikacin, any previous laboratory results or diagnostic results, and medical imaging. So you're going to assess the patient, whether the patient is septic, whether there is evidence of infection, whether there is any source of infection, and how bad the patient is. If the patient is septic, yes, it will be an urgent emergency. Patient may be in the ward or A&E. Investigate the patients. You're going to send them all the investigations as paired cultures. Why? Because most probably they have got an indwelling line and you want to sort of rule out colonization or a general blood infection. If you get culture positive in both, it will be bloodstream infection. If you get only in the lines, it may be colonization, which may help you further. Laboratory investigations, Justice Shastri has already said, we use PCT, some people use CRP, and we use a trend of PCT, which is normal PCT is less than 0.1. Any imaging, any source control, any abscesses which are drained, we need to send for culture. Then we need to prescribe, right? How urgent it is. We have to give prescribe the antibiotics and give, because it's very important to document as well, and how urgent it is. So, are there national guidelines? We have a national guideline. We then have an antibiotic policy. And are we following the antibiotic policy? Because that is made according to our resistance pattern and antibiogram. Allergy. Remember, all the patients are, little bit of diarrhea and nausea and vomiting, penicillin allergy. Do you face this problem? We face this problem all the time. What are you allergic to? Penicillin. I mean, they say, oh, how allergic you were? Oh, my mom said I was allergic and I've never used it since then. So it prohibits us from giving life-saving drugs. So we have to test what sort of allergy it is, what contraindications are there, and also the spectrum which we are thinking of. So documentation, right drug for the right patient, right dose, right time, and right duration. This is antimicrobial stewardship. You have to document it, document the working diagnosis, whom you have discussed with, how much time do you plan to give it, when do you plan to review it. Okay? Then focus nurse, because somebody else has prescribed, please don't forget to challenge if you are not happy. because you need to look after the patients as well, and you don't need to do any harm. So then you see, after reviewing, after a couple of days, you might get a culture results, then you may be able to stop the antibiotics or narrow the antibiotics, amend it, refer to hematologists or whoever, they need to come and see their patients, and then you can extend it. Most probably you might need to extend or switch or consider antifungals also and things. So you have got these hospital guidelines, we have got it online, and we go through it, look at that, antibiotic dosing, antibiotic stewardship, the sepsis as well. And so this is our sepsis protocol. We have got our first line as tazocin or Pip-Taz, and if the patient is allergic to penicillin, mild to moderate allergy, we give meropenem, severe allergy, we give Cipro. We add gentamicin or amikacin as required according to that. Now, if there is gram-negative, again we give, as I said, gentamicin. If there's an indwelling line, we might need to give glycopeptides. We give vancomycin infusion. How many of you do levels, vanc levels on a regular basis? We need to do, right, because it is nephrotoxic. Otherwise, teicoplanin is a good one. If there's abdominal infection, metronidazole, and keep reviewing it. We review every day and according to the trends, and when necessary, stop. Same thing for neutropenic sepsis. And antifungals, if the fever doesn't stop in 3 to 7 days, because invasive fungal disease is a big complication, and consider antivirals as well. Okay. So what I'm going to tell you is, do no harm. All of us have signed the Hippocratic Oath or said the Hippocratic Oath. Are we following it? Are we leading to resistance? We can do anything. Look at that leader who's climbed it. It's difficult. All of us are facing barriers. We are facing barriers too. We don't have money. We don't have resources in the NHS as what we used to have before. So we can do anything as a team. So in summary, antibiotic resistance is rapidly rising and can lead to 1 death every 3 minutes. Antimicrobial stewardship refers to optimal selection, dosing, and duration of antimicrobial treatment resulting for the best clinical outcome. Start smart, then focus algorithm has been used. It has been evidenced. We are also having in our hospital doing efforts for antimicrobial stewardship. And it has been shown to reduce broad spectrum antibiotic usage. But mainly, we should avoid harm. We should do no harm and reduce deaths due to drug resistance together as a team. Thank you very much, folks. Thank you very much.
So let me introduce our next speaker, Dr. Satyajit VK. He's an intensivist from Melbourne, Australia. He's a member of the Academy of Surgeons, RACS, Australia. And he will be telling us about Dare to Care, Managing Respiratory Failure in Pregnancy. Over to you, sir.
Good evening, everyone. Thanks, Chase and the organizers. In particular, Ajit, a friend of mine, and Pradeep. This is the pointer? Yeah. And the slide changer. Right. Now, as an anticipatory bail, I'd like to say I have no specific expertise in this field, apart from having trained in a very large medical colleges in India, in Calicut, in Kerala, where every medical graduate is expected to take 300 to 500 deliveries, which I have religiously done. And having worked in an institution in Melbourne where we do manage obstetric patients, but as I'm going to highlight, and as majority of you would know, the percentage of patients who actually come to intensive care is very low, if in a reasonable setup. So, like the cartoon there was, while it is a poor attempt at humor, it is also an indication that we are actually dealing with quite a patient. The woman is in a very difficult situation when they come with respiratory failure, and treat them kindly. In terms of the epidemiology, I put some information there that is meant to mainly highlight the fact people don't come with respiratory failure in isolation. People come with multiple things to intensive care, but only very small percentage of them do. And when they come, the actual number of patients who are mechanically ventilated is quite low, which is my experience as well as the data. And a word of caution about the data, a lot of this data come from US because of the large databases they have. They predominate the literature. And that is same with other topics as well. So always be careful about extrapolating that information to our Indian scenarios. Now, pregnancy-related mortality is low, and so it should be, but a majority are preventable if proper care is taken. And the majority are not primarily due to respiratory failure, as you can see in the slide. But when they are actually ventilated, the mortality is moderately high, nearly 8%. So that is something to keep in mind. Another factor to keep in mind is you are actually treating two persons, and that is a common dictum people say. So you actually have two people there, one the fetus and the mother. So there are consequences for the fetus, quite significant. In terms of I won't go into the details here. Two or three points to highlight here. There is a reduction of FRC with the implications for oxygenation, pre-oxygenation, and intubation, as well as any respiratory failure. Patients are the woman is in a constant state of hyperventilation with mild respiratory alkalosis, and they are working already a little bit harder. And you don't want to make them any more alkalotic with the consequences on fetal circulation. Airway, it's well known. There is technical issues with the laryngoscopy, but as well as with a very little reserve for oxygenation, and the fetus is at risk with any drop in oxygenation. So we have to be at most careful and anticipate. Cardiovascular, just purely to highlight the fact that there is a huge volume changes. There is also changes in the cardiac output and the hemodynamics with almost like a mild septic shock-like picture, but it changes with the trimester of the pregnancy as well. The aortocaval compression is well known, so I won't go into the details, so always be mindful of positioning them properly. The uterine blood flow doesn't have an autoregulation as such, and the pH of the blood does affect it. And so in terms of, and towards a term, the overall proportion of cardiac output that goes into the uterus is quite high. So keep those things in mind. In terms of coming to the respiratory failure specifically, it could either, obviously it could either be a conventional insult to the respiratory system, or it could be an obstetric cause. A lot of this information you can obviously read up in literature nowadays. It's information is at the fingertips. So we'll try to just talk about perspective and the main highlight point rather than go into each and every point. So in terms of the common causes, the acute pulmonary edema we will come to that in a moment, apart from heart failure, which in our context probably could be a worsening valvular heart disease in low socioeconomic status patients, but also preterm labor where the tocolytic use is quite high, and preeclampsia. The normal routine non-obstetric causes are like any other patient, but there are some specifics which will come in the coming slides. Acute pulmonary edema, the thing to keep in mind is nearly half of them are from tocolytic use or cardiac failure, but they do tend to and predominantly happen in the setting of preterm labor, mainly for that reason. The tocolytic use, beta agonist, are obviously used quite commonly, and the associated volume changes in the heart hemodynamic changes make them more predisposed to going into heart failure. The cardiogenic obviously happens predominantly peripartum, as most of you would know. So be careful around that time. Obviously, it can happen any other time. Preeclampsia, even though the percentage of those who go into acute pulmonary edema is low, they do get into trouble because they have other problems such as capillary leak and volume changes and things like that. One word of caution in those patients is you just be careful in diuresing them too heavily, because they already have a vasoconstricted circulation with a reduced blood volume. So you don't want to be diuresing them too rapidly or too heavily. So other than that, APO management is the same, whether it happens in a pregnant or other, just that be more careful. Diuretics, an IV if required, and fluid management as in any other patient. In terms of aspiration, pregnant patients are quite at a very high risk of aspiration, as we all know. They have an increased abdominal pressure, they are more recumbent more duration of the time. They do get some analgesics and sedatives, peripartum in particular. They do have reduced gastric emptying and gastric volume and acidity. All of this put them at a higher anesthetic risk. Now, it is not just for an anesthetic risk at the elective time, but they are also very high risk, obviously, in intensive care if they ended up needing respiratory support in the form of an IV or invasive ventilation. So we have to be doubly careful in these patients. In terms of an acute aspiration, it can simulate an acute asthmatic episode. Obviously, you won't have the associated features in acute asthma, because asthma will see that separately. Chemical pneumonitis can simulate very much like any other pneumonia, infective pneumonia. The changes could be more multilobar. You might see some evidence of gastric aspiration, but that may not be the case always. But fairly rapid onset and unpredicted onset. Treatment-wise, it's largely supportive, as you know. PE, it's rare, like any other population, but these patients are much larger possibility of having venous thromboembolic episodes due to stasis and various other hypocoagulable state. And in terms of risk factors, it's pretty much the same. The additional risk factor, it is the same as in any other patient with PE, hereditary or other thrombophilic conditions. Anticoagulation is obviously the mainstay. Just be mindful in the peripartum period about the half-life of anticoagulating agents. Clexane has a much longer half-life. If they end up needing a thrombolysis, obviously it's very risky. Particularly in the peripartum period is the highest risk. But there's been a lot of case reports and literature of thrombolysis being done in pregnant patients. In fact, the overall risk appears to be slightly less than what we anticipate. Now, obviously, we do have catheter treatments for PEs. But overall, mortality, if it does happen in PE, is quite high. So just keep that in the clinical suspicion need to be very high. In terms of pneumonias, pneumonia can affect like any other patients, and these patients have more hospital contacts, so they are more prone for getting infections. There is some specific reduction in cell-mediated immunity, which would make them more prone for influenza, COVID, and varicella and other infections. They do have consequence for the fetus, so that is something to be mindful of. The overall course is obviously can be more severe, even though the number of patients, what I have seen in real life is very low in an Australian setting. I'm not sure what your local experience is. Obviously, these patients are not able to tolerate hypoxia very well, so we do need to be very mindful of intervening early. They do tolerate NIV. In terms of very close monitoring and early admission to hospital and in a high dependency area might be warranted. In terms of the spectrum, the severity indicators for pneumonia, they are very similar to the general population, I would say. Some systemic indicators, including renal, metabolic changes, and vital sign changes, and PF ratio, obviously. Early anticipation and starting supports early and moving them to a very closely monitored environment. And I'm sure I don't have to tell you that's what we do, whether we also need to set systems in our hospitals so that that happens. Varicella is a fairly, as I mentioned, much more common, so be mindful of it. In terms of these patients, the antibiotic use, it's a huge topic. I won't go into it too much. In terms of varicella, just be aware of it, that there is very high mortality in them. In terms of acute asthma, there is a lot more asthmatics get attacks in the pregnancy, and they tend to be in the early part of the pregnancy a lot more, with the consequence for the fetus. Venous air embolism, very similar to amniotic fluid embolism, which we'll see. ARDS, there is a moderate data. This is a good example of the data. The mortality in the literature is showing a much lower mortality than the general patients with ARDS. So I'm not sure how reliable that data is. And the risk factors in the direct obstetric versus other non-obstetric causes are very common. The supportive treatment is very similar. Couple of things to specifically highlight would be ventilator management. They need the target SpO2 and the PaO2 need to be quite high, and the PaCO2 is generally should be kept low. The plateau pressure possibly could be a bit higher because of the reduced chest wall compliance, as well as the prone ventilation has been used successfully with adequate padding and supports in this patient. So it is still an option. ECMO use is still, there are reports about it. There is certainly literature, and I'm sure Indian centers have used it, or that's what I've heard. Permissive hypercapnia, because of the impact on the uterine circulation, we have to be careful. COVID-19, there is nothing particular about COVID-19 in pregnant patients. I think there is a lot of data on it in the last 2-3 years. Some of this data may be mid-pandemic, so I don't know how relevant they are now. Remdesivir and dexamethasone is used. In terms of there are meta-analysis, and there is a lot of data in this field. Because of the non-specific nature of it, I'll skip to amniotic fluid embolism in a very quick manner if the chair allows. This is a dreaded problem, but very rare and very catastrophic for the mother and the baby. So it could be the postulation of whether there is a physical transfer of debris into maternal circulation across placenta, or there is purely immunogeny. It's still being debated, but there is a lot of predisposing factors, but they still don't predict. So very high degree of clinical suspicion and immediate escalation, and a collaborative effort with this other teams such as anesthesia, obstetric team is very much needed in this situation. And they do have this sort of biphasic hemodynamic response, so early pulmonary hypertension, right heart failure, going on to left heart failure, with the consequence for largely supportive treatment, really. After 4 to 5 minutes of cardiac arrest, if it happens, unfortunately.
Dr. Satyajit, you will have to go
I'll
to the
wind up in
concluding
one more
slide.
slide. Yes. So need to be considered. Rest of it is predominantly common knowledge, very high degree of clinical suspicion, and a supportive treatment. CTG monitoring, this is just for you to make you aware that you don't need to know all the details, but you can still learn very quickly the basic decelerations and whether they correlate with the uterine contraction or not. So I'll skip that. It's mainly infection control issues in the peripartum period. So in summary, avoid hypoxia at all cost, both for the mother as well as baby, and you have very small margin of safety. Secondly, you're treating 2 patients. There is a range of obstetric issues you need to be aware of, all intensivists, even if you don't treat them, it don't work in a maternal center, and the risk that does increase the risk and severity for other illnesses. Thanks for bearing with my delay. Thank you very much.
Yeah. So, thank you, sir, for your nice presentation. And now I'd like to invite Dr. Shashwati Sinha, our next speaker. She is working as consultant critical care, Department of Critical Care at Manipal Hospitals, Dhakuria, Kolkata. And she will talk on cautious action, ICU pharmacology in pregnancy. Dr. Shashwati Sinha.
Thank you, chairpersons. And so my life, again, has been made much easier by my previous speaker, because he's touched upon a lot of things which probably I'm also going to focus on. So when we talk about pharmacology in pregnancy, why is it important? It's because there has been an increase in the obstetric critical care admissions over the last several years. And safe and thoughtful medication management is extremely important in a critically ill pregnant woman because, again, we are taking care of 2 lives, and being safe is the key to improving maternal as well as fetal outcomes. And as it has already been focused on, that there are several physiological alterations which affects practically every system in the body, and it also has a direct impact on the pharmacokinetics of all the drugs which we use in the ICU. So it's important to look at not only the nuances of metabolism, but how the ability of the drug to cross the placental barrier, all of these things need to be taken into consideration before we select the drug. And of course, there is extremely limited evidence as to how the drugs fare in pregnant women, because most of the trials have excluded pregnant women from their patient population. So when we talk about metabolism of the drugs, we start with absorption. And as we know that progesterone causes a delayed gastric emptying, and it also slows down the intestinal motility. Apart from that, the enlarging uterus causes a mechanical compression on the GI tract. Both of these actually can delay the absorption. It delays the time to achieve the maximum concentration of a drug. So if a pregnant woman is in pain and we are planning to give a dose of opioid, and if it is given enterally, it will take a lot of time for the drug to achieve its action which we desire. Apart from that, there is an increase in the gastric pH, due to which certain drugs like aspirin, the absorption is significantly reduced. However, there is an increased blood flow and vasodilatation which occurs during pregnancy. So if we administer a drug intramuscularly or subcutaneously, the administration or the absorption is significantly higher. Again, as we saw that estrogen-mediated changes in the airway mucosa and vascularity can cause an increased or an enhanced absorption of inhaled medications. And we also need to look at how much of the drugs cross the placental barrier. And there are certain drugs which cross the placental barrier and they become ionized because of the low fetal pH, and they're unable to return to the maternal circulation. So there are certain agents in which the drug levels become unreliable. After the absorption, we already saw, as my previous speaker elaborated, that there is a significant increase in the cardiac output, a significant increase in maternal blood volume and the total body water, all of which increases the volume of distribution of the medications. Because of this, for hydrophilic medications, and especially antibiotics, we may require higher loading and maintenance doses. Often it is very difficult to find out how much we need to increase the dose because, again, we are limited by the availability of therapeutic drug monitoring. Apart from that, there is a decrease in the serum albumin, as well as certain hormones are there which displace the drugs from their protein binding sites. So the drugs which are highly protein bound, a lot of these drugs, the levels become increasingly high, like sedatives, phenytoin, and valproic acid. So there might be an unpredictable increase in the drug levels. The maternal body fat also increases by around 4 kgs. So there are certain drugs like propofol, which can accumulate in the adipose tissue. And we also know that the metabolism of these several drugs can increase several-fold, and the renal clearance and the GFR can be markedly increased. So, and serum creatinine thereby, is not predictable to decide about how much drugs you need to give this patient. So, when we talk about categorizing medication safety in a pregnant woman, most of the drugs are transmitted from the mother to the fetus via the placenta, and we need to take care of the properties of the drug as well as look at the recommendations by the regulating agencies. Up till 2015, we knew that there were 5-star letter grading. So it was categorized as to A, B, C, D, and X, depending upon how these drugs had fared in several human as well as animal studies, However, ever since 2015, it has now changed, and we need to, the drug companies need to categorize the effect of these drugs as to how they fare in pregnancy, lactation, as well as females and males of reproductive potential. So we'll be focusing on a few issues which we face in the day-to-day in the ICU. Maternal sepsis is defined similarly, however, it relates to pregnancy, childbirth, post-abortion, and in the postpartum period. We could be dealing with infections in the pelvis, or it could be systemic non-pelvic infections like a non-pregnant patient. Early empiric administration of antibiotics, again, the 1-hour bundle is effective in this situation as all. Pelvic infections often require a polymicrobial pathogens to be covered, but we need to keep in mind that the changes in the cardiac output, the volume of distribution, the hepatic and renal function, as well as the albumin levels need to be kept in mind before we think about dosing these drugs. And also we need to understand that there is the 5 to 11 kgs increase in body weight during pregnancy. As we know that we calculate the GFR based upon the predicted body weight. But as we know that there is a significant increase in body weight during pregnancy, we might need to dose these patients depending upon the actual body weight rather than the ideal body weight. When we talk about fluids, as we saw, Dr. Sharmili was already mentioning, during pregnancy, there is a very narrow therapeutic index, especially during the time of labor, that these patients have an increased chance of going into pulmonary edema. So we need to individualize and be very cautious about fluid management in these patients. There are also several limitations as to how to assess fluid responsiveness, as a lot of these strategies which we use in non-pregnant individuals will not be applicable here. As far as vasopressors are concerned, norepinephrine is the first vasopressor of choice. Most of these vasopressors cause uterine vasoconstriction and can lead to fetal injury. So close monitoring of the fetal heart rate can be a surrogate marker of placental perfusion. The second choice, as in non-pregnant individuals, we know it is vasopressin, but here vasopressin can be dangerous as it can cause potent uterine contraction leading to premature birth and can also slow down the fetal cardiovascular system maturation, as well as cause a significant reduction in breast milk production and cause infant cardiovascular effects. The second problem which we might deal with, although it is very rare, is cardiogenic shock. The commonest causes could be cardiomyopathy, pulmonary embolism, or valvular heart disease. When we talk about treatment per se, vasodilators, nitroglycerin would be the drug of choice. We should avoid sodium nitroprusside as it can increase the cyanide levels in utero. Inotropes, milrinone would be the drug of choice, although we need to be cautious if the patient has renal dysfunction or if the patient is significantly hypotensive. Loop or thiazide diuretics can be used, but we need to keep a close eye as to the response. And beta blockers can reduce the myocardial oxygen demand, but that can be used only following stabilization of the hemodynamics. If there are arrhythmias which need to be treated, and we are thinking about beta blockers, metoprolol is the drug of choice. And we should always consider anticoagulation. We'll come to anticoagulation in a little bit. We should avoid atenolol because it can cause adverse effects on the fetus, and also caution regarding amiodarone. Mechanical circulatory support if required in the most severe cases, and as my previous speaker has already alluded to cardiac arrest in pregnancy, it's very important to make sure that the lateral uterine displacement is maintained throughout the resuscitation. If we talk about ARDS, what I would like to focus on is what kind of steroids we would use in pregnant women. As we know that most of the trials of steroids in ARDS or sepsis excluded pregnant women, and they mainly focused on using drugs other than dexamethasone, because dexamethasone very readily crosses the placenta and has a higher effect on the fetus. And so usually the drugs of choice would be prednisone or methylprednisolone. Although in COVID it was recommended that you could use dexamethasone if required. Again, we need to keep a close watch and balance the risk and benefit, and we should not restrict any particular drug if it is life-saving for the mother. When we talk about analgesia and sedation, the opioids are generally safe. Most of the drugs, the sedatives, will cross the placental barrier. If you want to use sedation, dexmedetomidine is probably better. It's better to avoid benzodiazepines, and we should prefer to go with analgo sedation, with opioids as the first line, and dexmedetomidine or propofol in addition to that. When we talk about muscle relaxants, again, non-depolarizing neuromuscular blocking agents can cross the placenta. Always make sure you use the lowest exposure, lowest dose, and the shortest duration. As far as venous thromboembolism is required, low molecular weight heparin and unfractionated heparins would be the drugs of choice. And vitamin K antagonists and the newer oral anticoagulants can cause fetal abnormalities, so they should be avoided. It is important to stop the low molecular weight heparin 24 hours before labor induction. But if the patient is at a high risk of thromboembolism, switch over to unfractionated heparin and stop the infusion about 4 to 6 hours prior to the surgery. We'll just stick on the obstetric emergencies. I'll just go quickly. It's important to know that there are a lot of drugs which come with their side effects, like methargin is contraindicated in hypertensive disorders of pregnancy. Tranexamic acid has an increased potential to increase the seizures. As for hypertensive disorders of pregnancy, we know magnesium is the drug of choice, but we need to be cautious about the drug levels, especially in patients with renal impairment. As far as peripartum cardiomyopathy is concerned, we should, there are several options. Again, because of limitation of time, I will not go in detail, but we should avoid ACE inhibitors, ARBs, SGLT2 inhibitors, and vericiguat. Thrombotic microangiopathies, again, are rare, but need to be considered.
May I request you to go to the conclusions slide?
Yeah. So we need to collaborate with our obstetric colleagues in order to optimize the outcomes. So to summarize, that obstetric ICU admissions have increased because of the physiological changes affect all the organ systems. We need to be aware of the alterations and monitor the patients vigilantly in order to ensure safe medications. Multidisciplinary approach is the key to obtaining good outcomes, and safe and thoughtful medication prescription should always weigh the risk and benefit in order to optimize maternal and fetal outcomes. Thank you very much for your attention.
Thank you, Dr. Saraswati, for that excellent talk on pharmacology in pregnant patients. Very nicely done. I would like to request all the 4 speakers on the dais for a quick question and answer session. Dr. Prakash, Dr. Nandita, Dr. Satyajit, and Dr. Saraswati. No, that Sumit is not there. Is Dr. Sumit available? Yeah. So any quick questions from the audience, please feel free to ask. We have the experts on the dais, and also my co-panelists are with me. Any questions? No questions? Yes, yes.
So, Dr. Nandita, I have a question for you. So, in your opinion, who is the most important person in your AMS team? I know you would say everyone.
In the AMS?
AMS team. I know you would say all of them are equally important, but I would ask you, who do you think has made a major difference? I'm sure you would have had AMS from before, but who was that who really made a change, and now whom you can't stay without in the team?
So, our microbiologists are really, so I showed you the 2 pictures. One of the microbiologists, he's really dynamic. He does rounds himself. Poor fellow has no juniors and everything, and he goes, there's every monthly meeting, he goes and presents all the data. He liaises with the nurses, he liaises with the pharmacists, and he's doing all the graphs and all by himself. And now he's doing the policy. For me, he has been a change person in the hospital. And I think they are going to develop the team further. They're going to have an intensive care person. We don't have an intensive care person at present, but yes. But I think it's a teamwork, isn't it? Yeah.
Yes, definitely. Thank you so much.
Thank you.
What is your opinion, Anusha? Who is the most important person?
Yeah, I was thinking, we also have a microbiologist on our team, and as you say, is very invaluable. But we don't have a pharmacist. We are just getting in. But I think I would really like to have a pharmacist on the team, because they are going to be a bit away from the patient, so they might be able to impartially tell us that, yeah, you need to stop this and something like that.
In my hospital, I'm very lucky. We have a pharmacist on the ward round every day. So we have, I don't even think about that, because right from the beginning I insisted on a pharmacist being there, and we have very good coordination regarding everything, all sorts, not only antimicrobial but everything.
Yeah, you're very lucky.
So I'm lucky.
Lovely. Thank you. Thank you for that. Any more questions? Quick questions?
No questions.
Thank you.
I don't see any questions. I would like to thank all the participants, the 4 speakers and my co-chair. Thank you so much for joining me, and I would like to conclude the session here. Thank you so much.